So, hello, Mike, again.
Hello.
Thanks for offering us your assistance, which now we will use in the forum of this interview after we had briefly met in the conference in Hungary last year. I really do appreciate this that you contacted me and offered that. We really appreciate this because we miss any kind of information on these matters here, I believe. So I don't remember if we had spoken much this time. Probably not. There was a lots of new people around and lots to talk. So once again, I present my organization and our audience, I believe, should be watching us to understand our expectations better. It's like a preparation for the interview. So we communicate for usually for most common people of Lithuanian, and this means we are not any kind of experts in the field you are in. So you presented yourself as a therapist, or somebody presented you as such for me. I also looked in the internet, found that you are a clinical counselor, and there are these things are all have to do something with psychology. And I also know such concept as psychologist, psychiatrist, or psychoanalytic. And so let's start from these very simple concepts because I believe that in America people are quite bent on those psycho things. I see sometimes in Hollywood movies. I like to watch sometimes they're lying on coaches and talking lots to those psychiatrists, psychotherapists. So probably it's quite usual there. Not so usual here. I don't even remind any movie seen on one with any psychoanalytical psychotherapist with a client. So please tell us what are those differences between those concepts and how should you exactly call yourself on your profession, and what do you particularly do, like generally, in that psychology field?
Sure. Sure. So, a few things. One, I don't have the time to do a full history of the development of the field, nor am I an expert in that. But I'll start briefly to say that in the United States, there are different titles and that would be used in other countries in Europe or other countries around the world. So, in the United States, those terms have a particular meaning. Psychiatrists now in the United States refer only to medical doctors who do a specialization in mental health treatment. And it's primarily medicalized treatment, meaning sometimes they do talk therapy, but many times they use medication interventions as their primary modality. I am not a psychiatrist. Psychologists in the United States are doctoral level therapists who often focus on research and assessment, but can also do therapy. I am not a psychologist. What I am is I have two professional licenses in the United States. The practice of talk therapy is regulated by every state in the United States via state boards, and those state boards have licenses. I'm a licensed professional clinical counselor and a licensed marriage and family therapist in the state of California. So for the United States, that's the model we have. There are similar kinds of therapists for people around the world, but every country is going to have a slightly distinct way of categorizing them and regulating the profession. For my profession, it requires us to do a master's degree after an undergraduate degree, and a master's degree has to be in the field of psychology, and then it needs to be followed by several years, usually, of what we call internships or associateships, where I train under somebody else with that profession, like an apprentice role. In that process, I trained with Dr. Joseph Nicolosi Jr. for 4 years. He is an expert on matters of homosexuality related to men in particular and helping people overcome unwanted same sex attractions and behaviors. I currently work on my own. I have a therapy practice in the United States in California, where I also work with many men who have unwanted same-sex attractions, but I also work with other people with other issues. And I also specialize in the treatment of obsessive compulsive disorder. Obsessive compulsive disorder and same sex attraction among men are highly co occurring. That means many people who have same sex attraction, who are men, also have obsessive compulsive disorder. And it's at a greater degree than in the general population. So that's a little bit about what I do and about the practice of psychotherapy in the United States and how it's evolved slightly distinctly in the United States as compared to maybe other countries.
Oh, now I see and understand. First time I'm hearing about the connection in between this compulsive disorder and the unwanted same-sex attractions. And so please let's get straight to the primary interest of our interview. Uh, as for our organization, what are we interested mostly? So those same-sex attractions and sexual identity disorders. In your professional opinion, in simple words, what are these two? How do you approach to them? If at the moment we can leave some your therapeutic methods for a while, like we'll get maybe later. What is that in general? Like born this way, or some obsessive compulsive disorder, or something else? What that means?
Yeah, that's a great question. There is no definitive answer that I know of that any one person can give. What I think is a good place to start is that in the American Psychological Association, which is the largest body of psychologists, I believe, in the world, it is clearly delineated or explained on their website, even in for the general public, that there is no consensus among even secular researchers and biologists and scientists, and that generally speaking, they acknowledge that most people believe it's some complex combination of biology or nature and predisposition and nurture or environment and experiences that contribute to the development of sexual feelings and desires and behaviors that they would call LGBTQ in the United States, or what we would say are same sex oriented. I think it's very good for people of faith to acknowledge that every human being is body and soul. I'm a Catholic. And so, as a Catholic, I see the human being as body and soul, but truly one. And anything that we experience in our body is not separate from our spiritual reality. So, the development of same sex attraction, in my view, likely is a complex combination of our experiences in childhood, our spiritual experiences, and our relationship with God, and the way that our parental dynamic influences our understanding of our maleness or femaleness as an individual, as a sexual identity given by God, which is rooted in biology, my being, human being, body and soul. And it is influenced further as I go into adolescence by my peer experiences, by my exposure to material in the world like pornography or license in movies and shows. It's further often influenced by experiences with adults when people are adolescents. So often we find there's a high correlation between adult sexual abuse of minors, and the minors that are growing up and reporting same-sex attraction have statistically significantly much higher experiences of childhood sexual abuse. So there are a variety of factors we look at, but those are some of the big ones. Parental influences in early childhood development, peer experiences, experiences with pornography and or molestation, and also the unique I don't know factor, meaning there's a mystery to the development of the human person that we cannot fully understand, but we can reasonably take positions to try to help encourage healthy development towards normalized sexual development for most children.
Mhm. From what I've heard, you mentioned those biological factors, but you didn't put or you put them just whatever we don't know place only.
Well, the biological factors we know more about. Some of them, though, are unclear in terms of what they are. We have estimates from twin studies and from other human genome studies that estimate biological predisposition towards developing same-sex attraction for men is estimated to be approximately 32 to 33% biological predisposition. But this is statistically far less percentage of predisposition than for most mental health issues, for instance, which have most of them an average of 40 to 45%, is my understanding, of predisposition. And no one would tell a child you were born depressed. You know, we say born this way for any kind of sexuality issue when in reality the predisposition biologically for same-sex attraction is far less than many other traits that we do not consider innate or born that way. The thing that is the unknown is that there could be various other factors that we don't even know yet of that could influence same-sex attraction issues. But I will say this, even in the Human Genome Project, Ghana et al., which is extensively mapped the human genome sequence, even the percentage of biological predisposition estimated to contribute to same-sex attraction, it's not clear that those factors, it's not one factor on the human genome, and those factors are not even necessarily about sexuality. They're factors that include things like likelihood to take risks or other factors that we don't even understand why those will be correlated with same-sex attraction. So there's a lot yet to be learned and known, but biology is not determinative of your sexual feelings into adulthood. There is far more that we know comes from the environment than from any of your biological predispositions.
Okay, to be simple, if one has this predisposition, yes, to this same-sex attraction, as you said, 32, 33%, does it mean he has or she has to become that same-sex attraction?
No.
Okay.
Many other things have to happen for that predisposition to develop into a disposition, into an actual attraction.
Okay, clear now. And then you were talking lots that, as understood, many things are still much unexplored about all those sexual attractions, probably in general, and same-sexual attraction isn't so. And I believe it's probably connected to history of all those at least psychological researches and science as such in the world, but probably the cradle of it is still United States. And so I have a question about that. American Psychological Association you mentioned already, and I must expose myself. It's only because I've recently read a book, The War on Psychotherapy, by Dr. Christopher Doyle. You probably should know him. Because here we don't have any information about that. So there were some special crucial events with that association, which probably influenced the further developments on the science research or whatever of these. I believe this was year 2007. As I know, you were not in a practice, but your mentor, Dr. Joseph Nicolosi Jr., he was somehow involved, as I read. So maybe you can tell what you know about those events. What was that?
I think it's important that I honor the limits of my knowledge. So I'll share a little bit about this, but I want to encourage people, if they're listening to this, to do further research because, like you said, there are books and resources that have taken a lot of time to painstakingly document some of these events as they unfolded. There was a committee, it was a task force to research sexual orientation change efforts, and that's how they defined any therapy that sought to help somebody overcome unwanted same-sex attractions or behaviors. That task force was not ideologically diverse, meaning basically everybody researching that topic was in favor of normalizing homosexuality. So that task force had a strong bias towards promoting homosexuality as a societal norm and as a societal good. And I can tell you that their conclusions, even with that bias built into their team, their task force, was rather neutral. They more or less said, man, we can't really say there's something wrong with trying to do this. The conclusions are unclear. We don't recommend it because we don't think it's a good idea, but it's not super clear to us whether or not there is harm from this or not harm. But then they tried to focus on their ideals for recommendations, but that's not necessarily what their research showed. So, within that reality, I personally have spoken to one of the lead researchers on that team, Dr. Lee Beckstead, who's a prominent gay identified psychologist. I have stood 3 feet from that person and heard him say to my face that he apologizes for excluding anybody from that research team that held a different viewpoint on the nature and the philosophical understanding of homosexuality. He acknowledged it was a researcher's error, it was wrong, and it should have been done differently. And he did this because he now realizes their results were unfairly misrepresenting religious individuals who have same sex attraction but do not identify as lesbian, gay, trans, or bisexual, because there is a distinct difference between a person who takes on their identity based on those feelings versus one who resolves distress around their feelings in the direction of their deeply held religious values. And those individuals are severely underrepresented in research and were not represented in the kind of studies done in 2007 and 2008 when they published basically their task force results on SOCE, sexual orientation change efforts. So that's an angle that I think is worth considering. But review this further. It's published, it's documented. There is a lot of history that has been done to make sure we don't forget what happened. So I recommend your listeners check that out for themselves.
Please, once more, just simply explain this term SOCE, as it's not known for our audience, I believe, for sure. Just to have them some hints what to look for, what to study,
Right.
what is that, and
Well,
why this. What was that task force? What it had to do, this SOCE? Because probably our audience does not know what they were concluding about.
Well, sexual orientation is a definition that is a term that is used in the United States to describe someone's sexual feelings and desires and often their behaviors. That is a term that is relatively modern. It's not one that goes far back into Western history. Sexual orientation change efforts, therefore, are just the general term used by the American Psychological Association for any therapeutic methods that seek to help somebody overcome, by their own stated goals, to overcome sexual attractions or behaviors that are not in line with their deeply held religious beliefs, or they'd find them to no longer be desirable for themselves. This can include anything from talk therapy, discussing therapy, to perhaps trauma reprocessing methods like trauma based cognitive behavioral therapy, or even prayer. And in many times, the APA, the American Psychological Association, has included research on this that includes non professional interventions that may be used by some therapists, but are predominantly used by practitioners of religion. So, prayer or other kinds of religious interventions. And they often don't distinguish between therapeutic interventions and religious interventions when they're defining sexual orientation change efforts.
Okay, understood. Thank you lots. Still, I'll try to use you. Excuse me for that. For walking through quickly through the events history and getting some more understanding on the developments of on those issues. If possible, briefly summarize American story about psychology and therapeutics in these fields of homosexuality, transgenderism, if I call it correctly. How did they look like before the Stonewall events? What were these major changes? One we were talking about already, yes. From that until nowadays, what did they happen? If you can get some just few crucial moments and some names for a case, what to look for somebody
I think
who's
the development of the view of homosexuality in the United States is very, very complex and not one that we have time to get into. However, aside from the cultural development that may have influenced the professional changes, I'll focus on the professional changes. So, in the early 1970s, amidst a variety of other factors, including the sex research in the 50s that was led by Alfred Kinsey, and the sexual revolution led by the hippie movement, and the introduction of abortion and birth control proliferated throughout the United States. There are so many factors that historians refer to when they're talking about why the culture's view of homosexuality begins to shift, among others that I haven't mentioned. So let's just say a lot was happening in the United States as a result, it seems, or at least connected to this in some way. The general psychology community changed their definition of homosexuality in the early 1970s from being a disorder to no longer a disorder, from being seen as what they called a paraphilia of some sort to no longer a paraphilia. They did, however, allow for there to be what they called ego dystonic homosexuality. That means somebody has homosexual feelings, but they don't like it. It doesn't fit for their life. They don't want to live that way. That was then later further removed from diagnostic categories in the United States. And my understanding is in the late 1980s sometime. This further marginalizes people who have homosexual feelings but do not want to identify with them or act on them because now they're not even recognized as legitimate at all. So, fast forward over the next 30 years, there's a huge cultural swing. Gay marriage is adopted as the law of the land, as they say in 2015. Around that time in the United States, at the court case Obergefell versus Hodges in the Supreme Court of the United States, this comes concurrently with many laws being passed for minors to prevent what they call conversion therapy for minors, which is anything like we're doing to help people with unwanted same-sex attraction and behaviors, even if it's healthy and non-abusive, and if it's, very careful and gentle, and it's according to the client's needs. The courts are still starting to strike that down, or to basically make those laws sustainable in the United States starting in the early 2000s. So now we have a huge cultural shift. Many religious people currently identify gay marriage and homosexuality as morally licit, so good. And this was hugely influenced by these decisions along the way. We've got the diagnostic categories changing, then following.
okay. Sorry.
Yeah, so I see we might need to reset the meeting.
Sorry, we'll fix that. Okay, please.
So we have the diagnostic categories changing in the medical textbooks. Then we have from there, to summarize, the laws changing in the United States for therapy and for gay marriage, and all of these things influence the cultural perception of homosexuality and also the landscape for therapy as over the last 30 years, things have shifted significantly.
Okay, thanks. Now about this sexual orientation change efforts connected to your therapeutic practice directly. What methods and principles do you use and how do they work? Also just very simple, are they effective? How do you work on that?
Right. So I think it's important to acknowledge that that term sexual orientation change efforts is used by people who oppose usually the work that we do. It is not language that we tend to use. One example is we might use the term sexual attraction fluidity exploration in therapy, what we call safety. And
Mhm.
the reason to define these terms more clearly is because it is often a war of words. People are using language to try to marginalize or to try to demonize the other side. I don't try to change anyone's sexual orientation. When people come to me when they have distress about their emerging sexual feelings or their behaviors, what I try to first do is help them look at their entirety of their whole self, body and soul, and to see if they have healthy sense of self. I used a lot of the work of a couple of Dutch psychiatrists named Dr. Conrad Bars and Dr. Anna Theroux. They use the term affirmation therapy, but you can call it other things. The basic principle is every human being is born into a family and is meant to learn that they are lovable and good just as they are. Many psychological dysfunctions flow from a child not learning that in their childhood. Some researchers call this attachment, having a secure attachment to your parents. Okay, so starting point, anybody that comes to me with same-sex issues, I'm going to wonder and be curious with them about their sense of their lovable self, if they believe themselves to be good and lovable. If we address that first, then contrary to our critics, we will help somebody have less shame about their experience of same-sex attraction. Even though many critics of the work that we do say that we're harming people or shaming people, we say no. We're helping them learn they're lovable and good just as they are, even if their sexual attractions, feelings, or behaviors never change, or if they never get over them or never heal from them in the way they hope to, they are loved by God, by others, by me as a therapist. I care for them. I want them to find themselves to be lovable and good. Second, we want to look at traumas and things they have been to
Yes.
that may have influenced the development of these feelings and behaviors. For many of my clients, we have to look, therefore, at obsessive compulsive disorder issues. We have to look at early childhood or adolescent experiences with sexual molestation, and we use standard evidence based methods like cognitive behavioral therapy and other trauma reprocessing like eye movement desensitization and reprocessing called EMDR, which is internationally utilized for the treatment of trauma as we help people address relationship dynamics with themselves, with God, and with others, with addressing past traumas, many times for some people, they find their sexual feelings become less intense towards the same sex, or they find themselves able to better manage and direct their behavior to be more in line with their conscience and their religion as a result of addressing these things. Also, many people have addiction to pornography. So we're using standard treatment in our field to help them address sexual addiction, like pornography or sexual acting out. So, those are the focuses we take. Emotional health and well being is the focus. The result of that is sometimes people have a change in their feelings or behaviors, and they're better able to live according to their conscience. We're not trying to change anyone's feelings or behaviors as a direct goal, though. That is a byproduct of the work to help them be a healthier, happier individual.
Okay, so even if it's a byproduct, can I say that the problem of this unwanted sex attraction is family, not biology, usually? So,
I think that, it's predominantly not biology. It's predominantly family and other experiences for many people. We can't say for all people in all circumstances, but we can say for many people. That's what I see in my clients. And they may have some people a small degree of change in their lives, some people have a significant degree of change in their lives. But either way, they have the right as an individual to seek healing and change as they see fit, as long as they're not harming themselves and as long as we're trying to help them live in a healthier way. So, with that said, many people say, well, the change and the degree of change is not significant enough, and therefore there might be disappointment. Well, that's true with almost any goal for somebody's health and well being. Many people struggle with being overweight. In the United States, we have many obese people, and many of them try to lose weight and are not very successful or not as successful as they want to be. They might have some disappointment, but they'll still be better off having, let's say, tried to be healthy than if they just never tried, or better off being 10% less overweight than they were, even if they aren't 100% less overweight. So we should apply reasonable standards and expectations for any major life change or behavioral change, or address this in the same way. The issue is that many people don't see this as a valid goal. So someone who doesn't see it as a valid goal to try to leave homosexuality or try to reduce their same-sex attractions or behaviors will dismiss or discourage those from trying, but that's not their place to do so. Every person has the right to choose their own goals and their own path for therapy.
So we go further. So from what you talked, can I guess that if I ask you your measures, how do you measure your effectiveness of your work? You would probably answer me that it is by the increased satisfaction of your clients on their life, yes, more than of something if they moved totally, not totally from former sex attractions or these things. Am I right?
I think I mean, we do measure, I would judge it based on satisfaction of life, well-being, etc. But also client self-report, do they feel like they're meeting their goals? Are they happy with their time in therapy? I also work for myself, but I collaborate with, I mentioned Dr. Joseph Nicolosi, who runs the Reintegrative Therapy Association, which I am on the board for that nonprofit. And we utilize standard measures, including sexuality questionnaires, and every 6 months at my practice, we do assessments to see there are measurable ways there are ways to measure progress towards certain goals. So we also take a look at data and see where people's sexual thoughts, feelings, behaviors, and other mental health issues, depression, anxiety, obsessive compulsive disorder. And we track that. I track that at my practice every 6 months with clients. So there are ways to gauge this and that are not just subjective self-report in the moment. It is all subjective self-report, but we can actually do it through assessments. And many people I know do that as well. So people try to use data to help guide and gauge treatment.
Okay, so what are your assessments are like? I don't know, something in
I mean, I just listed a few. We have the sexual fluidity questionnaire. We have a sexual attraction questionnaire that was developed for the clinic that I used to work for. We have standard assessments for obsessive compulsive disorder. We have standard assessments for autism spectrum and other things like major depressive disorder assessment. So these are the types of assessments we use that measure and gauge both the quality of somebody's fantasies, what they're thinking about, their behaviors, and their ideal sense of self. Am I okay, do I have what we call a mindful response to my sexuality? In other words, do I see it and I have a sense of compassion towards myself and curiosity, or is it judgmental and harsh? So self attitudes are measured, but there's a whole variety of assessments I use, but many therapists use other assessments, and that's okay. Everyone has their own way of tracking these things.
Okay, by tracking, I'm just interested. How do you assess your assessments? I mean, what are the numbers or whatever? Can you say it's rather working effectively or it's on the way?
There's no way to compare because every person's different and unique. So the degree of change or experience of shift to one person to the next is going to be totally relative to where they started. I have some clients who are so severely depressed, not just because of their same-sex attraction issues, but because they have severe depression issues. And that person going from severely depressed to moderately depressed is a success. Whereas somebody who is coming into therapy not depressed, if they leave moderately depressed, it's a whopping failure. They have gotten worse, and life experiences influence people's development over time. So I hate to be oversimplified here, but there's no way to really gauge exactly that person's success except for based on that individual starting point. And then from there you can say, hey, this is what we review with the client, this is what we're seeing happening in your results. Does this feel like it's helping to you to the degree you want it to stay in therapy? And I really want to emphasize therapy is professionally guided, but it is self-change. So people are trying to make changes in their own lives, and those changes are going to continue whether or not they're meeting with me in therapy or whether or not they're on their own, because it's their own life that they're trying to influence outside of whether or not I'm a part of that process. So what we want to do is try to help them move towards their goals even in during the time we're together, but even after as well.
Okay, understood. So, trying to finish this part with your personal practice. So, do you still have many clients? Are they coming forth and forth? Does it mean that you have a job and they're quite satisfied? People recommend you. I mean, is that working
Yeah, I mean, I
for
think a lot of people find benefit from treatment. I have a small practice, so I don't work in a full-time practice. I work part-time as a therapist, and that's intentionally. There's no shortage of people that need and want help. I think many people that I've worked with have found it to be a positive experience, but maybe not everybody. I think generally speaking, my reputation is that I care far more about clients knowing that they are good and lovable and that God loves them and finding ways to help them live with reduced shame and increased sense of self-worth far more than their just behavioral change or whether or not their feelings shift. So that's part of my mission as a therapist is to try to help people integrate with their sense of their goodness given to them by God, instilled by their dignity through the death and resurrection of the Lord. I'm a Catholic, so that's very important to me. And if I work with non-Catholics, which sometimes I do have Muslim clients and non-Christian clients, I will still work with them and help them to know that they are good and lovable based on their own religious perspective. But this is far more important to me than specific behavior changes, although many people find that they're able to reduce, that I've worked with, reduce their unwanted behaviors or shift their way of looking at themselves towards their goals, whether that be marriage or living a celibate life, etc.
Okay, thanks. And for me, especially is interesting. Maybe that's based on some of my prejudices. But the question is, how do you manage to perform this kind of job living in Los Angeles, California? I believe
I
it's
think,
a quite most woke state and
yeah,
city also.
I
How,
think
yeah.
I just do my own thing, to say it in a colloquial way. I just practice my therapy and I trust that God has given me a call to try to work in this way right now. And primarily, I just keep my head down and go forward. I don't worry about what other people think or say about me as much. And I think, generally speaking, it is not popular, but there are a lot of Christians in California. There are a lot of Catholics. So there is a subset of the population that is still significant in size due to how big this state where I live is, that want help and want encouragement,
Mm,
especially as things become more woke, as you said.
yeah, I see. But maybe they are not like becoming totally woke, or like there is some balance sometimes, and they're getting back sometimes, isn't it? So, how do you see as a professional now the prospects of American psychotherapy on those discussed fields and upon the cultural and other things which you were telling a little bit? What could be the influence of this to this so-called LGBT people, society as a whole, or even maybe to other countries and other issues like families, democracy, religion? Are they somehow interconnected? Like what happens in this science can influence some issues with the religious freedom
Sure.
or democracy. I was not just speaking about that woke term.
Yeah. Yeah, okay, so you're asking a very complex question that I could not possibly answer in full, but I will say one thing that comes to mind is anything I think about or talk about in this field is rooted in my understanding of the world as a Catholic. And Catholics were given this tradition called the Catholic social teaching, and it's developed more explicitly over the last 150 years, and it really has been since the time of Judaism into Christianity and beyond that the family is considered the center anchor point of society. The family is the building block of culture and of society. So any attack on the family as a nuclear family, being mom, dad, and child, undermines societal well-being. And that can flow into forms of governance and how we treat citizens and how we view rights of individuals. So I do think that this attack on the creation of man and woman in God's image is a significant threat to general Western development and well-being. In terms of psychotherapy, how that applies, the problem is that these laws that are passed in the United States seems to have an oversized influence on the field of psychotherapy abroad. And so as they make it more difficult for people to seek help for their unwanted same-sex attractions and behaviors, I fear that it may influence other countries to model that same way. The kind of unique aspect, and maybe you could say the fatal flaw of the other side of our adversaries, is that they have lumped together transgender issues for children with same-sex attraction issues, and they seem to have overplayed their hand. Many parts of Europe right now are starting to walk back their view of transgender issues, but because they were tied to what they called conversion therapy, now those issues are being brought under scrutiny as well for minors. So the shimmering little bit of hope is, in my view, that places like Great Britain and places like Scandinavia are starting to shift because of their national health system seeing the potential harms done to children. So we might see this challenge the United States actually to rethink their position on these issues. And we also, as you know, Thomas, have the conservative Supreme Court right now in the United States, which may in the next decade or so have a significant influence on these laws abroad as well.
Okay, so from flowing from that, the last questions. Uh, I was talking with you like a professional psychologist, member of various professional organizations. And do you collaborate with other kinds of organizations or other kinds of professionals from other fields in
Sure.
what is important in that? What are expected or even fulfilled outcomes of that?
Yeah, I do personally collaborate, but I'll also comment on the general collaborations I see happening among others. So I am involved with the Catholic Psychotherapy Association, which, as it might be worth noting, has available online for purchase seminars. Joseph Nicolosi Jr., Dr. Nicolosi, and myself presented there in April of this year on this topic on reintegrative therapy. And so I collaborate with them. I'm on the board for a group called the Alliance for Therapeutic Choice and Scientific Integrity, which focuses on same-sex sexual issues from a Judeo-Christian perspective. That is a sister organization to the International Federation for Therapy and Counseling Choice, the IFTCC, which you know that's where we met, as you mentioned. And so I work with Dr. Mike Davidson. I work with many different organizations. And the reason I'll bring up the only way it matters about my personal collaborations is that they're indicative of others' collaborations as well. So many of these organizations, like the Catholic Medical Association, the Catholic Psychotherapy Association, the IFTCC, the Alliance for Therapeutic Choice, they have like-minded individuals who are striving to try to influence culture towards a healthier rooted position in Catholic worldview or Judeo-Christian worldview. And this underground, these grassroots organizations that are not funded by major donors from large political groups, they're really small groups that are trying to build steam through evangelizing culture one group at a time, one church at a time. And you know them because you're involved with them as well. So I think people should be encouraged to know that there are many people. They're not a mighty giant organization, but there are many organizations that are small but mighty in number, or mighty in spirit, I should say.
Okay, and just for closing, so even if you don't know many probably, but what would you wish for our professionals in this field, our organization as Lithuanian Family Movement, members of it, and just for all common Lithuanians, for people from
Yeah.
Lithuania?
I guess anyone listening to this, I would want, if somebody has these struggles, you know, an individual with same-sex attraction, I would like for them to know that there is help and support available, even internationally, through ministries, through professional organizations, so that they can reach out for help. I would like professionals to consider that the predominant narrative from the United States is not the only way of looking at this issue. So there are people like me and others, many others, who want to advocate for a different way of doing things that honors the individual's conscience, that roots our way of practicing and the dignity of the human person as made in the image and likeness of God, but as male or female based on their sexual identity, rooted in biology. And that research is being done, but there needs to be more professionals. So get on our team, join us in this conversation, help us move the ball forward. We need you in Lithuania. We need people in Europe to help us all defend the Christian worldview and defend the rights of individuals to seek help for these issues. That's my hope, my encouragement that we can be collaborators internationally and not see each other as disparate floating islands, but as really one human family trying to support each other in this goal to help people with same-sex attraction.
Thanks a lot, Michael. We'll reach to the IFTCC, I believe, because I saw there's a representative of Lithuania already there. So we have some people even in some places already. I was very glad to meet you. I hope we'll meet soon again somewhere in Europe, maybe. And thanks again. Have a nice day. Thanks.
Absolutely. And my best, and God bless you and your work you're doing. And, I send all my support and encouragement as you try to encourage people along their way.
God bless you.
Okay. Thank you.